Hello and welcome to our oral health presentation for Head Start Health Coordinators. I'm Nancy Frank Wilson with the Minnesota Oral Health Coalition. On behalf of our coalition members, including the presenters today and their organizations, we want to thank you for all you do for children's oral health. As we often say, there is no health without oral health. Let us begin with our first presenter, Clare Larkin.
Hello, my name is Clare Larkin. I'm a retired dental hygienist who spent my professional time in oral dental hygiene education, clinical dental hygiene, and then my last working years in public oral health care. And I've a long-time dental hygienist, and I'm still very much committed to this effort. So along with other dental hygiene colleagues, we've remained committed for more than 2 decades to support Minnesota's Head Start programs. We know that there is a need to meet oral health assessment and referral and follow-up care requirements. Today's presentations will offer administrative and policy efforts, in addition to how integration of a collaborative practice dental hygienist can offer just one part of the solution. You won't hear all the answers today, although throughout each person's segment, you'll hear plans for continued conversation. So let's get started, and I'll turn you to Amy.
I'm going to share my screen here. I'm going to stop my video while I do that.
Wonderful.
Okay. Hopefully everyone can see my screen.
Yes.
Yep. Okay, great. All right. My name is Amy Zeitz, and I am the Child and Teen Checkups Policy Person at the Department of Human Services. Before I came to this role, I did want to let you know that I did work in a Head Start program for over 10 years. I started out as a health coordinator and moved into a supervisory position as an associate Head Start director. I'm very familiar with the Head Start performance standards, and from the time I worked in the program, very familiar with the challenges faced by Head Start staff as well as families to get their kids in for the needed medical and dental visits to meet the federal requirements. So these are the things I want to briefly touch on during this conversation. Just basic, what is child and teen checkup, some state agency responsibilities. We're just going to view the best practice dental periodicity schedule, and then I want to show the support that you have from DHS for the collaborative dental hygienist work, and I'll share my contact information. There's so much to learn as a new Head Start staff person, so ask questions, utilize the resources that are shared here today, and I hope that I can bring some clarity and understanding on this topic. So a little background of EPSDT and what that means. Like, you have the Office of Head Start as the federal agency. We have the Centers for Medicare and Medicaid that governs the Medicaid program. One benefit of Medicaid is the early and periodic screening, diagnostic, and treatment benefit, which is a program for children, teens, and young adults ages birth through 21 that provides comprehensive preventive health services. Program goals are to keep kids healthy by getting them in for their preventive visits, identifying any concerns that parents or staff might find on a screening that is part of the periodicity schedule. And of course, we want to help the family build lifelong healthy habits. There are 2 parts to the program. You're probably most familiar with the clinic visits. The other piece is outreach, which is typically your local public health program, some tribal health agencies, as well as local clinic or clinic systems that are responsible for outreach. So again, the federal name for the program is the Early Periodic Screening, Diagnostic, and Treatment, EPSDT, and in Minnesota, that benefit is called Child and Teen Checkups, and it's called something different in every state. So the Department of Human Services is the state Medicaid agency, so we are responsible for the administration, implementation, and oversight of the program statewide. We're responsible for any policy related to a child going in for their medical or oral health visits, and then payments of those services. As mentioned, county public health agencies, tribal programs, and health systems are contracted to do the outreach piece of the program. And then, of course, we can't do this but on our own. And so we have an interagency agreement with the Minnesota Department of Health that brings in their clinical expertise. So with that interagency agreement, the Minnesota Department of Health is responsible for any sort of health consultation. So if there's questions from providers, Head Start agencies, public health agencies, the Department of Health can help with the clinical piece of it. They keep us informed of best practices that are happening in child preventive well care, which includes the American Academy of Pediatrics or the Centers for Disease Control. So they're looking at those federal agencies, making sure that we're on track in our state. And then, of course, they provide training to providers, local public health, and other agency partners who are providing the screening to children. So this is straight from the Head Start health-related performance standards, which references programs following the early and periodic screening, diagnosis, and treatment guidelines set forth by the state Medicaid agency. So again, the Department of Human Services is the state Medicaid agency in our state. And so again, following our periodicity schedules to make sure that children enrolled in Head Starts are up to date on their primary care and oral health care. Briefly, this is just the Minnesota specific dental periodicity schedule, which follows the recommendations of the American Academy of Pediatric Dentistry. So in a perfect world, every child would be seen at a dental office twice a year. However, because there's a shortage of dentists that have the capacity to see children that are covered by medical assistance, we had to collaborate and find another strategy to meet the needs of children enrolled in early Head Start and Head Start. And so one such strategy came about years ago to combat this shortage of dental professionals and help Head Start programs meet their standards. This practice, the collaborative dental hygienist practice, was accepted by the Department of Human Services in 2013, and nothing has changed since. This is a screenshot of a letter sent to the Region 5 office in Chicago from the Minnesota Department of Human Services, letting them know that the collaborative dental hygienist model used in Minnesota Head Start classrooms is consistent with requirements in the Head Start regulations. From that same letter, if you read the last sentence, it clearly states that the Centers for Medicare Services approves the hygienist model as meeting the oral health requirements set forth by Minnesota's EPSDT program. And you might notice that this letter references the old performance standard number, but nonetheless, the content still remains true. And this is a screenshot of a letter back to the Department of Human Services from the Region 5 office, again, providing acceptance of the Minnesota Department of Human Services assurance that this practice is acceptable as required by the state's early periodic screening, diagnosis, and treatment schedule. I'm happy to answer questions folks have, hear comments. I'll share my email address on the next slide. If it's worthwhile for me to come back and talk about other topics, I would be happy to do so. So please reach out to this email address. And I certainly want you to know you have an ally at the Department of Human Services. I want to be a helpful partner to give kids the best possible outcomes. And I will now turn it over to Nicole and stop sharing my screen.
Thank you very much. Just one moment here. All right, can everybody see my screen?
Yes.
Perfect. Thank you for joining us today. My name is Nicole Ferrian. I am a dental hygienist and Apple Tree's Clinical Innovations Director. I have had the privilege of providing dental services to children at Head Start settings, and I'm grateful and excited to be here with you today. Our agenda will include a short overview of Apple Tree Dental, a description of our community collaborative practice model. I'll describe how dental services are provided at Head Start centers, and we'll end with an introduction to a new preventive and decay arresting treatment available. And just as a side note, you'll hear me use words like caries and decay throughout this presentation. Those are just technical terms for a cavity. So Apple Tree is a nonprofit dental practice with 9 locations in Minnesota. We are one of the largest critical access dental clinics in the state, proudly serving patients regardless of insurance type. Our mission is to overcome barriers to oral health, and our vision is to foster partnerships that create healthy communities. As I mentioned, we have 9 centers across the state of Minnesota. Those are brick and mortar centers, which you can see are listed and depicted on the map here. We also provide mobile care at community sites. Our typical target population are low-income children and families, adults with disabilities, and seniors and elders in long-term care. As Amy mentioned, and for those that weren't previously aware, the dental access issue for those on medical assistance is significant in Minnesota. It's very difficult for members on medical assistance to find a dentist that accepts their insurance. For that reason, as you can see, over the past 2 years, our patients came to us from all 87 Minnesota counties. While we're grateful to provide care to members across the state, there are patients that travel hours to see us just because they're not able to access a dentist with their insurance closer to where they live. The community collaborative practice model allows us to serve patients where they are at. Providing dental services at Head Start centers is one example. Through our mobile program, we also provide services at medical clinics, long-term care centers, and facilities that serve individuals with disabilities. We also render comprehensive services in schools. We rely heavily on partnerships throughout the community and with community partners to do this. Let's get in a bit more into how we provide care outside of our brick and mortar locations. So our centers for dental health, the 9 that were listed, are the hub in a hub and spoke model for the delivery of care in the community. So Apple Tree uses trucks to carry mobile equipment. It is not an RV model where there's a schedule and they hook up to a building and provide care. Instead, we employ drivers to transport and set up equipment at partner sites so that comprehensive dental services can be provided there. We also maintain an electronic health record that allows us to send our data from our clinics and our mobile sites. Here are some images to demonstrate how our mobile program works. The truck, which transports the dental equipment, is stored at the brick and mortar location. In this instance, this building is Mounds View, which is our largest center. And just to note, not all of our centers have a mobile program, but there are various ones in the metro and then also in greater Minnesota that do. The driver transports the equipment late afternoon, and then the dental team arrives the next morning to set it up and get their day started. And here's just a few images so you can see what that process looks like. This, I believe, is in a long-term care facility. So this is what our mobile dental offices look like once they're fully set up. So typically setups at our Head Start centers are more simple in nature and focus on preventative care. This here is an image of an Apple Tree dental hygienist at a Southwest Minnesota Head Start center. Care is routinely provided knee to knee, and oftentimes the parent is involved in the process and also educated along with the child. Let's take a few minutes to understand how Apple Tree typically delivers care at a Head Start site. The Head Start delivery model focuses on prevention and appropriate triage. Preventative care and education is provided to all children, and referrals are made as needed, utilizing community relationships to find sources of care. And what I mean by that is, as you can see from the last one, there are struggles sometimes to find care for those children that have restorative needs. And so we rely on working with the county public health, the Head Start contacts, ourselves, and then local community clinics to provide care for the child. Previous to the visit, so previous to Appletree's visit to Head Start, Appletree works with the Head Start contact to complete the necessary patient paperwork and create a care schedule for the day. The contact brings the children to the dental hygienist for care on the day and then escorts them back to class. If parents are present, they also participate in the visit. What I found is that oftentimes this is the child's first dental visit. Once at the setting, the ones that I've been at are typically in a gym within the building. The child and the dental hygienist are knee to knee. Oral hygiene instruction, typically around brushing and flossing, is reviewed, and diet is discussed at a high level with the child and more in detail with the parent, depending on what the findings of the assessment. We also provide preventative care. We screen and look for any issues, count to ensure the child has the appropriate number of teeth. We also do a toothbrush prophy, which would be a toothbrush cleaning so that we can clean and remove all the plaque from the child's teeth, and then also teach them how to do it. We bring mirrors as well so that the child can watch us. We also apply fluoride varnish, which is a vitamin to help make children's teeth stronger. And previously there used to be trays of fluoride and there was a foam that was applied in the tray and the child would have to keep that in their mouth. Now it's just a little paintbrush. We talk to children and let them know that it's kind of like painting nails except for painting teeth. So it's just a sticky substance that's applied to the teeth with a little brush. And then intraoral images and documentation are taken by the dental hygienist and sent back to a teledentist who is able to review the documentation from that day and identify the findings that need to be followed up on if necessary. For children in need of restorative care, i.e. if they need a filling or an extraction or something to that degree, families are followed up with to schedule the treatment that's needed. This is usually at Appletree or a different entity within the community. A care coordinator from Appletree works with a designated Head Start contact after the teledentistry exam is done to communicate the existing needs of the children and put a plan in place for addressing the decay. As I mentioned, if the site is near an Appletree location and we have the capacity to care for the children restoratively, we will typically see them. Otherwise, I've been in different locations where there's community partners, like a pediatric dentist or another dental clinic that's willing to see the Head Start children to address their needs. Approximately 30% of children have active decay. Less than 10% have urgent needs. Children identified with concerns typically need 1 to 2 visits with a general dentist. Only a few of them need to be referred to an actual specialist, which is a pediatric dentist. Most general dentists treat children. Those that have significant behavioral or dental needs may need to be seen by a pediatric specialist who goes through years of additional training in pediatrics. This is an older image, but depicts the process of taking intraoral images to send back to the dentist, who will do an asynchronous, which means not live, dental exam. This is what the intraoral images look like. The teeth are captured to ensure that the dentist can see all of the dentition, but then also there's areas of concern are captured and noted for review. This is Dr. Cernahouse, Appletree's primary teledentist, just reviewing some of the information that was captured on site. Another thing that I wanted to talk to you about today is silver diamine fluoride. Silver diamine fluoride is a non-invasive caries treatment option that is getting a lot of attention lately and could potentially be implemented in a Head Start setting after a caries diagnosis. This isn't routinely done currently, but a future opportunity that Appletree is reviewing. The current barrier is that Minnesota requires a dentist or a dental therapist to diagnose the decay prior to the hygienist applying the silver diamine fluoride. This is the depiction of the simple tray setup for silver diamine fluoride. And this is how it works. So as you can see from the images, those brown spots in between the teeth, that's dental caries. And then the second picture below is after silver diamine fluoride treatment. Silver and fluoride penetrate the tooth and they are deposited within the decay. It slows and prevents the caries or cavity process, and it strengthens teeth. For us, SDF is currently used in clinic and mobile settings to arrest or to kill the decay. It's great for pediatrics, special needs, and the elderly population, as we don't need to use a drill. Oftentimes, it can help arrest the decay while the patient is waiting for an appointment, either with a general dentist or a specialist. This just goes further into how SDF works, just talking about how it kills the bacteria, and then it also reduces sensitivity. The advantages are that it's pain-free, and as I mentioned, no need for a drill or local anesthetic. It's very quick and easy, aids in prevention due to the fluoride and silver, and it's inexpensive. It does not come without side effects, but staining and the metallic taste are the primary side effects. In regards to staining, the decay permanently turns black, which is why some parents prefer to only have it applied to posterior or back teeth. And care is needed to ensure that the product does not get on tissue or skin, as that will temporarily stain, and supplies like clothing, counters, etc., as that will permanently stain. This is just a case example where a 3.5-year-old who was medically complex had SDF placed, and then that was to arrest the decay prior to getting in with one of our specialists. So there was active decay, the SDF was applied, then reapplied, and then they were able to do the filling. So this is just speaking to how if a child has active decay, this can be applied to reduce sensitivity and pain, and also arrest and stop the growth of the decay before being able to get in to a specialist or a general dentist for filling. Thank you for your time today. I hope this information was helpful. I have included my contact information so that you could email me with any questions. With that, I will stop presenting my slides and turn it over to Claire.
Thank you. That was fabulous, Nicole. So I am going to be talking about some opportunities for resources and support, and I know that Prasida also will also be talking about resources available through the state. So to begin with, I'll introduce you to some of the resources that we've know of, and also some that we've been working in collaboration with the Minnesota Oral Health Coalition to provide, and that is an online toolkit. Can you see my slides okay?
Yes, it looks great.
Okay.
Yeah.
So in 2015, Normandale Community College received a Major Health Resources and Services Administration, or HRSA grant. One deliverable proposed by Dr. Colleen Brickell, who is Dean of Health Sciences and the lead on this HRSA grant, was to support professional dental hygiene efforts. As grant activities were being planned and as we were having meeting after meeting, a vision started to come forward that this is really about a 21st century dental team. A workforce model was born. One outcome of the grant was development of a collaborative dental hygiene practice settings toolkit. In 2023, that toolkit, which had originally been housed on the Normandale website, was moved to the Minnesota Oral Health Coalition website. So Nancy is becoming very familiar with collaborative dental hygiene practice. The toolkit section is accessed via the coalition website. You can see on the menu tab at the bottom of the screen, I have the menu tab circled in red. A section of the toolkit promotes a team approach, including the decades-old effort that Amy talked about since 2013 for collaborative dental hygiene practices in support of Minnesota Head Start programs to meet oral health requirements. This is the welcome page on the Minnesota Oral Health Coalition Toolkit website, and collaborative dental hygiene practice information we're building it out very wonderfully to include information that will be helpful to you as well. Here are two examples of collaborative dental hygienists, and Nicole very thoroughly talked about what she as a collaborative practice dental hygienist did. On the left, we have Eva Romero, one of our colleagues who is doing parent education, and Holly Jorgensen on the right that is doing classroom education. And as Nicole said, that's really step one of trying to influence the concern we have on access to oral health care, and that's education. You will note at the bottom of the page that I inserted a note that a collaborative agreement is not needed, however, for a dental hygienist to go into a community setting, a school, a Head Start center. That can be done by any dental hygienist. However, I like to show the importance of the oral health education being part of that visit. It's not just about going in and providing the care. It's to inform the children and the parents of how to prevent that care. So what is collaborative practice in community settings? It was inserted into law in 2001, as Amy alluded to. It's important to realize that the agreement is between a dentist and a dental hygienist. A collaborative agreement, which is a written document, is not needed between a dentist and your Head Start center or any community program. For Head Start purposes, collaborative dental hygiene practice offers that option that Nicole talked about for families and students who require a dental appointment. Collaborative practice offers the oral health assessment, triage, referral on site, rather than seeking appointments in traditional dental offices, which are very difficult to come by for underserved populations. In 2006, our colleagues, who include Deb Jacoby, who many of you know of Apple Tree Dental, developed a calibration method for dental hygienists interested in the Minnesota Collaborative Dental Hygiene Practice opportunity. The intent of the initiative was to standardize the assessment, triage, and referral to fulfill the Head Start standards for around oral health. Amy previously referenced the paths and challenges that were encountered during those early years, some of which are still needing some clarification, but there has been a concerted effort just to keep this moving and to keep it a viable option. You can see on the slide in front of you that many of you are no doubt familiar with the left slide, how dental hygienists can improve oral health for Head Start participants with the Office of Head Start and Early Childhood Learning and Knowledge Center. Excellent materials that are provided around oral health on that site. And then the dental hygienist liaison is a an option that some of you maybe are familiar with as well. The dental hygienist liaison is a position for a volunteer dental hygienist in a state to assist and promote and help be that communication between the oral health professionals and Head Start. We have a section on the toolkit on the online website, and it's, as you can see here, titled Head Start Dental Hygienist Liaison Project. And Kathy Jo Gunvalson is a Minnesota dental hygienist who for years has fulfilled that state position. And again, it's a volunteer position. If there is a particular document or materials that would be fitting for this section on the website, we'd love to hear from you. Also, let us know if you see any outdated information on this toolkit. We're really trying our best to keep this updated, to keep it current. And this is Kathy Jo Gunvalson from Gonvick, Minnesota, and she has given years of her time on a volunteer basis to make this go. So if you know of any dental hygienist who is interested in that volunteer position, we would love to hear from them. So as I said, the website is a work in progress. We'd love to have you contribute materials or give us a jingle and say, hey, had you thought about putting this document up or that document? I know that Nancy would really love to have it be a live document, not just something that's put up there and then left for people to find or not find. So Nancy is really great about promoting the social media and opportunities for learning. And so between Nancy and myself, we look forward to hearing from you and send any questions that you might have. Thank you. And I'll pass it now to Prasida.
Thank you, Claire. I'm going to share my screen. Claire, are you able to see my screen?
Yes,
Yeah.
it looks good.
Okay, and then would you let me know if I'm when I'm advancing the slide, if you are still seeing my previous slide, would someone let me know, please? Sometimes that happens. Okay. Thank you, Claire, for passing it on to me. Hello, everyone. My name is Prasida Khanal. I serve as the State Oral Health Director at the Minnesota Department of Health. And today I'm talking to you on behalf of Brushing for Two initiative, which is part of our larger early dental disease prevention initiative. And we call this initiative Minnesota's equity approach to advance oral health promotion for maternal child health population. I have three goals for my presentation. One is to really provide you the landscape at the state level and really to let you know how oral health is an equity issue. Second, I'm going to share resources for oral health education and referral. And third, I'm going to talk about our partnership with Minnesota Head Start Association and some of the exciting opportunities that are being planned for early Head Start and Head Start staff. So talking quickly about the oral health inequities that we are seeing at the state level, many of you already know that historically dentistry has been separated from medicine, and doctors are doctors, dentists are dentists, and doctors are not talking to clients about brushing and flossing, and dentists may not be talking about exercising or diet and things like that. So historically, dentistry and medicine have been separated. That's the reason why it's separated from insurance system, from payments, from medical education as well. So the body wouldn't know these separation rights, and they didn't sign up for this arrangement. And teeth, they don't know that they are supposed to keep their problems confined to the mouth. And this separation sometimes leads to real consequences. Like in case of DeMonte Driver, a young boy in Maryland who lost his life because of the tooth infection that affected his brain, and he lost his life because there was no access to oral health care. There was another story, and I'm sure like this is the story that you often hear in Head Start setting. So this little girl was undergoing multiple extraction, which means the dentist had to pull multiple teeth for her and asked her parents to not to give anything to the child by mouth. But the surgery had to be canceled in the operating room because the child showed up with a donut. So the reason why the child showed up with the donut was that the family understood that nothing by mouth meant that all of the girl's teeth were going to be removed, and they worried that she would be hungry after the operation. So they thought she needed to have something to eat in the morning. And this is a very common scenario with our early Head Start and Head Start families, and that's where you come in as the messengers of oral health. There are multiple barriers our families face in terms of seeking, reaching, and receiving care, and you have the ability to advance oral health equity, and I'll tell you how you do that. So first, you can start by triaging the oral health issues, whether it's a pregnant mom served by early Head Start or kiddos served by Head Start. You can simply ask a couple of questions, screening questions like, do you have any dental issues, and do you have a dental home, right? And based on those questions, there is a decision tree that you can use to make an appropriate referral. You can also incorporate a caries risk assessment tool, which is a simple questionnaire that would help you assess the risk for tooth decay for a child. So you can also simply lift the lip of the kiddos in your classroom periodically to look for the signs of tooth decay. You can also provide fluoride varnish or have your staff do that. And there are nurses who could do fluoride varnish, and there are also dental providers who would come to Head Start programs to provide preventive services. And there is also a fluoride varnish card that you could use so that it facilitates referral between medical and dental providers. There is also a goal setting sheet that you can use so that parents are aware of good oral hygiene practices for their kiddos. Early Head Start staff enhance maternal child health populations motivation to change, and I've seen you guys do that so well. So we would really encourage you to continue doing those motivational interview with your pregnant people or children, caregivers, and then help them really change their behaviors for optimal oral health. We also have oral hygiene kits and those little business cards with a QR code that will bring clients back to our website for more educational materials. So this is a conversation starter for you and also an incentive for families for taking care of the oral health. There is also opportunity for you to use this timeline to talk to families about the importance of oral health and different milestones and different oral health practices for children. Most of the times, I know at Head Start, parents are concerned about the amount of toothpaste, when we should change our toothbrush, when our kiddos ready to floss. So there are multiple, information sheets that you can pass to the families as well. So for your classroom circle brushing, I understand you are doing those dry toothbrushing, and there are always questions about spitting out the toothpaste and not really needing to rinse. So there are different best practices for classroom circle brushing, and in the future we'll take a deeper dive into those best practices. But there are resources available on Head Start Association official website where you can pull these flyers, and there are also videos that you can watch. There are several other handouts that MDH has developed. This one is particularly for pregnant clients served by early Head Start, where a client gets information about prenatal oral health and the importance of maintaining good oral hygiene during pregnancy. There are also brushing for two. These are more like infographics or flyers that we have that are geared towards a pregnant person, right? And also for infants. Milestones for Mini Mouths are oral health educational material for the newborn, as well as until a child is age 1. So it's more like their first birthday best practices for oral health. We also created Happy First Birthday, Little One, a birthday card, because this can be sent out to those new moms served by Early Head Start. And it's a reminder for them to not just take care of their child's oral health at home, but also how they can get connected to a community dental hygienist who can do a preliminary screening, education, preventive services, and then refer the child to a dentist if a follow-up care is needed. There are multiple other flyers that talk about the value of prenatal oral health, as well as the best practices for children that you can use. I know there are family fun nights at Head Start, so we have a very fun fishbowl activity that we can do with families to show them actually how cavities are formed inside the mouth. And this is a very educational way or approach for us to educate the families and really encourage them to adopt healthy behaviors. We also can help you do baby showers. So let us know if you'll be interested in hosting baby showers for your Early Head Start clients. There are also America's Tooth Fairy materials. These are whiteboards that are very popular. And I know Minnesota Oral Health Coalition also had some of these resources. So we'll talk to them about your needs and see if they are able to provide you some of these resources. You can also promote drinking tap water. We have a flyer that really encourages families and children to drink tap water instead of sugar-sweetened beverages and snacks. And there are also grant opportunities for you to apply for these hydration station grants or water bottle filling stations. And then quickly talking about the partnership with Minnesota Head Start Association. As some of you might already know, we do have a Minnesota State Oral Health Plan, but there isn't a specific section for Early Head Start or Head Start oral health strategies. So all the presenters who came together for this presentation represent different agencies, and we all have agreed to come together to help Minnesota have Early Head Start Oral Health Plan, which means you would have access to a collaborative approach for Head Start and Early Head Start kiddos. We would also be hosting quarterly lunch and learn through Minnesota Oral Health Coalition. It's going to be a virtual meeting where you get to meet with all the important oral health partners. There would also be technical assistance through discussing different oral health topics. We are also thinking about finding funding for a designated community dental hygienist who could serve as a hub for all your needs and technical assistance. And all the presenters who have gathered here today are supporting this initiative. So we are very excited to be coming to you as oral health community, and you wouldn't have to go looking for each one of us separately. So those are exciting opportunities, and you will hear more about these events from Minnesota Oral Health Coalition in the near future. So just to conclude my presentation, I just wanted to re-emphasize that community programs for maternal child health population, including Early Head Start, community health clinics, all the social service agencies, community health workers, we all form a dental home. Dental home is not just having a kid see a dentist at a physical site, but it's a whole spectrum where we do community clinical linkages. We help our families with addressing social determinants of oral health. And then at the end, we establish a dental home or continuous access to care for our pregnant clients as well as for children. And we would like to thank you for all the hard work you put in to make sure that kids have access to dental care. So with that, I am sharing my email on the slide. If you have any questions or would like to connect, please feel free to reach out, and I'll be happy to follow up with you. Thank you. And I will pass it on to Claire.
You're on mute, Claire.
I'm on mute. Of course, we would have to have at least one presentation with that happening. I just want to say that my heart is filled with just the information that I heard, and just this collaboration between the 5 of us has the potential to grow, to keep moving this information further in support of the communities that we serve. So it's so great to have a strong Department of Human Services and Minnesota Department of Health leadership, and the Oral Health Coalition, and providers and people with efforts such as Apple Tree Dental. So I thank you all. And as Prasida stated, please know that we are here for questions or information or support at any time. And the coalition, it's fabulous that it's leading this charge right now. So thank you, Nancy.
Thanks, everyone. We appreciate it.
Thank you.